Good afternoon. My name is Emma Vanilla and I'm a market researcher. We have a team of highly specialized individuals that are going to talk to you about the biology, pharmacology, development, and marketing of this drug that we believe can top the antidepressant market. Now, our drug is an Ianlafaxine, which is a type of serotonin and norepinephrine reuptake inhibitor, or SNRI. Now, why should you invest in our antidepressant? Well, first of all, the OECD has ranked Australia as second for antidepressant prescriptions. From 1990 to 98, antidepressant use doubled, and then from 2000 to 2011, use increased significantly again. This increase in trend can also be seen in the United Kingdom and America, which demonstrates a huge market for this type of drug. Now, when SNRIs were first approved in 1993, they quickly took the market by storm, as it was quickly evident that they were more effective, better tolerated, and safer than the SSRIs that were currently used to treat depression. This can again be demonstrated in 2014 as two of the top antidepressants were SNRIs. Christique, a desvenlafaxine, which works similar to our drug, was second place, and although relatively new at that point, in 2013 it managed to make $600 million. And this figure was expected to rise as it was replacing an older SNRI, venlafaxine. Now, these drugs do have a very long list of side effects, which is their only downfall. These side effects include seizures, high blood pressure, and even hepatitis, and they also can interact badly with common drugs such as aspirin and painkillers. These are the flaws in the market that we want to address in order to top it. And in addition, we want to make sure that our drug can be able to treat a number of ailments, because the top SNRI in 2014, Cymbalta, managed to make just under $3 billion simply because it could be used to treat a number of conditions. So if we can address these problems and make our drug able to treat a number of conditions, we believe we can dominate the market. I'm now going to pass you to our biologist, Dr. Amy Bowden, to talk to you some more.
Depression is an incredibly complex biological disease. Different regions of the brain are responsible for different moods, emotions, and physiological actions, and when some of these areas are altered, a disease such as depression can result. In recent years, scientists believe the disease was due to a chemical imbalance in the brain, or in particular due to low levels of the neurotransmitter serotonin, which is commonly referred to as the feel-good chemical. The only supporting evidence for this belief, however, was that when some patients were given medication to elevate serotonin levels in the brain, it helped alleviate their symptoms. After more recent research, scientists like myself began to notice that brain cell growth and connections may actually be a more significant factor in the biology of depression. When the brain of a depressed individual is observed, it is often found that the hippocampus is smaller than it is in the brain of people who are not depressed. Differences can also be noticed in other areas of the brain, but the hippocampus is so important as it controls memory and emotion. The longer a person has been depressed for, the smaller the hippocampus becomes. The cells and networks of this region appear to literally deteriorate. Stress is believed to be a trigger in the decrease of new neurons in the area of the brain. It has been shown that when the hippocampus is regenerated and new neurons are stimulated, the person's mood significantly increases. Drugs that contain serotonin help their consumer by promoting the release of other chemicals, which then stimulate neurogenesis, which is the growth of new neurons. Genetic factors have also been shown to have a significant impact on a person's likelihood of developing depression. A particular variation in the serotonin transporter genes leaves individuals more vulnerable to depression. Every individual has 2 copies of this gene, one from each parent. Each gene can either be long or short. In one study of 800 individuals, it was shown that 33% of people with one short gene became depressed after stressful life events, and people with 2 short genes were even more susceptible. This makes sense considering that depression and bipolar disorders often run in families. While there are countless studies suggesting more factors that can come into play in the onset of depression, and that the exact cause of the disease remains unknown, it is evident that depression does have a biological basis, which has psychological and social consequences. Depression can affect a person's life in many ways by causing a loss of interest in daily activities, difficulty sleeping, anger, irritability, loss of energy, and weight changes, just to name a few. Dr. April is now going to explain how Ianlafaxine can alter the biology of a depressed individual's brain, thus eliminating these symptoms.
Hi, I'm Dr. April and I'm a pharmacologist. I'm going to tell you a little bit about how our drug works. Serotonin and norepinephrine are neurotransmitters that are located within the brain, and these neurotransmitters relay messenger signals between cells and the brain. SNRIs have a dual action, binding to the serotonin and norepinephrine transporters and have a low affinity to other receptors within the body. If you have a look at the picture, you can see the nerve terminal releasing these neurotransmitters into the synaptic cleft. SNRIs delay or block the reuptake of these neurotransmitters, serotonin and norepinephrine, by the synaptic nerve. The levels of these two neurotransmitters are therefore increased within the synaptic cleft, and it is this increase within the synapse that it is thought to elevate and improve the overall general mood of the person. Ianlafaxine is absorbed easily from the gastrointestinal tract, and it is extensively metabolized through the liver. Once metabolized, renal elimination of Ianlafaxine and its metabolites is the main route of excretion. Compared to SSRIs, SNRIs have a significantly greater reemission rate. It has a low risk of causing pharmacokinetic drug-drug interactions and a low risk of toxicity due to an overdose. Other things like weight changes and sexual dysfunction, which is usually a very common side effect, are also at a much lower risk. I will now hand you over to Dr. Sean, who will tell you a little bit about the development of our drug.
I'm Dr. Sean Faulkner, and I'm part of the development team for Ianlafaxine. When we first discovered Ianlafaxine, we ran computer simulation models to determine what effect it could have on the human body. These models show that the drug is readily transported into the human brain and that it has a high affinity for the active sites responsible for blocking the reuptake of serotonin and norepinephrine, and a low affinity for other active sites. This indicated that the drug is ideal as an antidepressant as it has a reduced risk of side effects and a low dosage requirement. However, we still need FDA approval before we can market this promising drug. In order to get FDA approval, we still need to conduct a few more physical trials. These physical trials are animal model trials and human clinical trials. The animal model trials will be done in order to determine the therapeutic index of our drug and to prove that our drug is safe enough to conduct human clinical trials. Human clinical trials will be broken up to 3 phases. The first phase will use a group of healthy volunteers, and this is done in order to determine the potential side effects our drug could have. The second phase will use a small group of people who suffer from depression, and this will be done in order to fine-tune our drug's dosage. The third phase will use a much larger group of people who suffer from depression, and we will use a placebo and our medication in that test. This is done in order to prove to the FDA that our drug does indeed have a therapeutic benefit. And we are confident in our drug's ability to pass these tests. We've already started marketing our drug, and for that, I'm going to pass on to our head of marketing, Dr. Jara.
Hi, and thank you, Dr. Faulkner. Here at Sager, our marketing team have come up with a snappy name for our new version of Ianlafaxine, which is Ianlafaxine. We chose the name Ianlafaxine for its ability to be easily pronounced and easily remembered, which will make it more likely to stay in the minds of our potential customers. In Australia, it is not legal to directly advertise prescription medication to consumers. Therefore, we will be targeting our marketing strategy and branding towards general practitioners and hospitals. In the development stages of Ianlafaxine, simulations have theorized that lower dosage of the active ingredient is required for therapeutic effect. Because of this, our product has less severe side effects, is less reactive with other drugs, and is much safer than our competitors' offerings. This enables Ianlafaxine to be prescribed for a number of different ailments, and it is even safe enough for use in children, which will open up a broad market and help to maximize profits. At Sager, we are 100% confident in Ianlafaxine, and we truly believe that it surpasses our competitors' antidepressants. Our marketing will be transparent, honest, and it will reflect our confidence in this product. We will advertise to GPs and hospitals in a way that arms them with information about why Ianlafaxine is more effective in treating depression. We intend to make the GP feel like they have the very best tool for combating depression and helping their patients get healthy. To conclude, we believe that Iafexa has the potential to dominate the market share due to its high level of safety and broad usability. And a final message to our investors. Our goal is not profit maximization. We do not cut corners. Our goal is to create the most effective treatments we can to benefit the public. This will in turn lead us to profit maximization. Thanks.